And thank you for inviting me. And I'm going to try and put together some of the themes that I've just heard and that people are talking about. I too would like to make a land acknowledgement, acknowledging where we are on the land of the Kenora peoples, but importantly also as Canadians, we too, in the spirit of truth and reconciliation and respect the self-determination of our First Nations, Métis and Inuit people and their rights. And I have the privilege of working and playing on the unceded traditional territories of the Musqueam, Squamish and Tsleil-Waututh nations, as well as the chartered Métis Nation of the Lower Mainland. So for my disclosures, I was an English Lit major before I went to medical school. In fact, I wasn't going to actually be a doctor. I've also had a lot of participation in the KDIGO Consensus Conference on Nomenclature for Kidney Function Disease, which was held in 2019. And I've been a part of a number of work groups and consensus meeting discussions on chronic kidney disease, acute kidney injury, acute kidney disease, and kidney failure. And I actually believe that words matter and actions matter, as Stephen and others have alluded to, but if you don't have the right words, you can't get to the place where you can do the actions. So what I want to do is just take about 10 or 12 minutes to discuss why nomenclature is important, a historical perspective of changes in nomenclature and nephrology and how I think they've actually helped us and what impact that has, importantly, on people for choosing words wisely, whether that be in clinical conversation or in research conversations. So I think that using nomenclature in describing kidney function disease in the scientific literature was not and is not uniform. You will see words like, and I'll come to this, that actually confuse people. And if you're a person living with kidney disease or a patient or a clinician, if we're using different words, it's going to be a problem. And I think consistency improves communication because we all know who and what we're talking about. Nomenclature can influence communication at a number of different levels. Most importantly, about how people feel about their disease, a greater appreciation for the public of what disease. I don't know how many of you went to school and knew what a nephrologist was or what a renal was, because I don't think it's very accessible. And if we understand these changes in words, then we have a better recognition of the gaps in knowledge. And then that precision in language helps us to guide not just getting people into studies, but actually then translating the results of those studies into a language that everybody understands, because otherwise you can't advocate. So, as I said, both healthcare and research requires a communication between individuals, but you're transmitting not just information, you're also transmitting thoughts and feelings. And if you ask someone if they have pain and they say no, that doesn't mean they're not feeling discomfort. You have to find the word in their language or their context that actually helps them. And that communication can impact people's health outcome, quality of care, satisfaction, cooperation. And interestingly, if you ask women if they have chest discomfort in the context of wondering if they've got an acute heart event, they'll say no. But if you ask if they're short of breath and excessively fatigued, they'll say yes. And you know, that's exactly the symptoms that women have that are very different than what men have. And if you don't ask it the right way, you won't understand what to do next. And I think importantly, communication is more than just the words, it's the eye contact and the listening and the feedback and recognizing the person as a whole and as an expert in their situation. And so one of the things that I've learned in our clinics is that if you start out with, well, you're doing very well from a kidney perspective, but what's on their mind is they can't pay the rent and their mother is sick and they have to figure out who's picking up the child. They can't listen to anything about kidney health or disease or anything you're trying to educate. So understanding where people are at, which is one of our challenges, I think. One of our challenges, I think, as we think about the use of Zoom and virtual stuff, it's not quite as easy to get eye contact. Precision in language is also important. It helps us with clarity of thought, and I think it makes it clear what we're talking about and who, and we sometimes are quite flippant about that. It also helps with interactions with grant agencies and colleagues, and I think Stephen alluded to this. When you're talking to ministers of health or policymakers, they nod, but they don't always understand what you're saying. So you have to sometimes bring it down to exactly what you're trying to say. And the clearer your question, we learn this in research, the more likely you are to have an answer, and it improves any scientific program. So When we met a long time ago to describe the principles of nomenclature, we said we needed to have language that describes kidney function and diseases that are patient-centered. So failure versus what's an end stage something? Like it's not clear, but the patient said failure actually makes sense in kidney versus renal. So the precision is around, the kidney has lots of functions, not just filtering things. And yet we use GFR interchangeably with kidney function. That's not actually correct. And there are different ways that we describe things like chronic kidney disease and acute kidney injury and all their stages. But if we actually improve our patient-centeredness and precision in the way we describe things, then it might actually be much helpful to align all of our goals. So just to take a step back, there are a number of public health strategies to promote kidney health, and awareness and burden of disease is one of them, but you have to figure out how to make that into a language so that you can generate solutions. And we went to our Indigenous people and they said, please don't come and tell us what else is wrong with us. So we have a kidney screening program, which is called Kidney Check. And it's about how healthy are the kidneys in your community. And can we help find people at early stages where the kidney health isn't so good so that we can actually then get you to the right care and processes. And that has met with a lot of engagement from communities because they didn't want to hear yet one more time what was wrong, but rather how many maybe didn't have perfect kidneys and what could we possibly do. So we have a screening program that's called Kidney Check within the CanSolve. So just back to some of the craziness of kidney world. So when I started in nephrology, which is now a very long time ago, there was something called pre-renal insufficiency. Now just think about those words. I don't even know what they mean now, but we use PRI as if it was something that we all understood. Pre-dialysis basically means your destiny is dialysis, doesn't it? But that isn't what we really meant. And renal insufficiency is another thing that I never understood. So right now people have kidney diseases, or they have chronic kidney disease, and then you figure out why. We also had words like end-stage renal disease and end-stage kidney disease, but we've decided, along with patients and families, that kidney failure is actually what we're talking about. It's not an end stage of something. And then renal replacement therapy is another one of those funny words. It's really kidney replacement therapies, and it can be a dialysis or transplantation, and that's what we do. So many of you will know that we had a definition and classification of kidney diseases, which I was quite privileged to be a part of way at the beginning. But the rationale was that if we had this uniform, explicit terminology and objective criteria, we could not just be better communicators, but we could actually find people earlier, intervene earlier, and improve outcomes. And to the point that I think people were alluding to in the last conversation, it's fine to have a better way to access transplantation, but if you can't access identification of kidney disease in the first instance, then that may not be the whole answer. So why do we define things, not just in medicine, but in life? And why do we classify things? Because you want to know, is something present? And if so, where is the person in the natural history? So definition is recognizing, and classifying is figuring out how bad it is and what types of interventions might you implement at different times. And then if you think about a transition from health to structural injury and damage to changes in function to disease, then it's a little bit more accessible, I think, and a little bit more understandable to people. And that was one of the issues. So the definition of chronic kidney disease is that it's defined as an abnormality of structure or function that's there for more than 3 months that has an implication for health. Why does it say that? Because if you have a simple cyst on your kidney, it probably doesn't have a huge implication. So we didn't want people to get all excited about the wrong things, but rather to understand how to do the right things. And I'm not going to bore you with this, but it's more than just a number, and everybody gets excited about GFR and what the number is, but it's way more than that. And one of the people in the video before talked about going with polycystic kidney disease and recurrent stones. And, when someone has any abnormality of function or structure, which includes making stones, one should do an ultrasound and would have been found a lot earlier, one thinks, rather than 4 years of hospital admissions. This is just part of the reason that we do this. So if we define populations with kidney problems consistently, and then we consider how you have a care model that's specific to that stage, where you sit on severity and any unique conditions you have, then you actually can figure out what best to do. And since we started defining CKD more consistently, So it was 2002 that the first KDOQI guidelines were published with the new nomenclature. And in 2012, we updated it. And the increase in publications, because people could study it better, more consistently and understand it, I think has really been exponential. I should probably update this slide. But so there's another condition that we have, which is acute kidney injury. And in the past, we talked about ATN and ARF, which also didn't mean very much. And now we have these two words, acute kidney injury and acute kidney disease. And the point about this is, if we don't have a systematic way to identify, like we do for heart attack. So what's a heart attack? It's an acute cardiac injury, right? But we never had that word in the kidney world. And so we were getting all mixed up. So we now know that very small changes in kidney, in creatinine actually lead to poor outcomes. It doesn't always require dialysis. And acute renal failure made it sound like you needed dialysis, and that was the only way you had a really bad kidney injury. And so again, my analogy of acute kidney injury is the same as an acute heart attack. You have evidence of damage, and now you need to know what to do. We're not nearly as advanced in the AKI world in terms of studying it properly or understanding it. But if you start with awareness and recognition, and we have a program in our province of now when people have acute kidney injury in the hospital, where we're going to give them a little pamphlet of what happened and what their doctor should do and how they should follow up. That's kind of where we're at. I'm going to skip over this notion of acute kidney disease, but it's ideally that acute kidney injury is time limited within the first 7 to 14 days. And if it doesn't get better, then we call it acute kidney disease. This has caught on far less well in the nephrology world because people are like, don't think about another thing. And yet the cardiologists come up with HepPef and HFrEF and all these new words, and everybody gloms onto them. And we come up with like a simple phraseology, and nobody wants to use it because nephrologists are like that. They have to debate something a long time. But it's actually a totally logical extension of the AKI, AKD, CKD. But if we were to consistently identify these people who didn't get all the way better, but didn't need dialysis, and figure out why, we'd learn more. We'd be able to identify a whole bunch of therapeutic targets. We might be able to design clinical trials, and ultimately we'd be able to take care of patients better, because we wouldn't just wait for their acute kidney injury to get all better before you called them CKD, and then they sit there for 3 and 6 months. And I always find it interesting when I do rounds with the residents. So if this AKI occurred a month ago, why isn't it now AKD? Oh, we didn't think of that. So that's how it goes. So there's a conceptual thing about how we link all these together, but that's not really the point of today's talk. So Stephen alluded to a network that I also have an amazing privilege of leading, which is called Canadians Seeking Solutions and Innovations to Overcome Chronic Kidney Disease, because we needed a cool acronym and I had to fit in the words. So it's actually Can Solve CKD. And it actually does have at the center of its patient governance. We have a patient governance circle, and we have an Indigenous Peoples Engagement and Research Council. And one of the articles that you quoted up there in terms of the cultural perspectives and narrative and systematic review is from the CanSolve group, looking at that. So the patient's perspectives, I think, I've learned a lot from both our Indigenous partners as well as our other partners, which represent often other marginalized groups in terms of their ethnicity, language, et cetera, within Canadian society. And so what they've taught us is, they say, like, help me understand what is my condition, where am I in the journey, and what do I need to do? And then tell me what I'm supposed to do with perspectives, right? And so using the words properly are right. And so I just reflected on imagining some conversations that you have if you use the old words and the new words. So you have acute renal failure or ATN. Like, we used to say that to people, right? But if you actually say you have acute injury to your kidneys, and we call that acute kidney injury, and the usual causes are drugs and infections, and we need some time to see if it gets better. That's way different than, oh, you have ATN. It also is a way better to teach students and teach patients. You have an acute sudden kidney disease. It has a name. This is where the glomerulonephritis and the vasculitides might fit in. And we have a number of different treatments for you. So I think it's important that we imagine another way to talk with people and not to them from our word. And then if you imagine, again, these conversations with old, and you have renal insufficiency, pre-renal insufficiency, you're a pre-dialysis patient, we're going to send you to a pre-dialysis clinic. I'd be petrified, right? It means that the only hope for me that I get to look forward to is that I get to go to a dialysis at some point. But if you have said, if what we say, which is what we say now, is you have chronic kidney disease, we'll send you to a kidney care clinic. There are lots and lots of causes. We think the cause of yours is this. We can stage it, and that'll help us with planning and treatment. Totally different conversation. Or you have end-stage failure, kidney disease instead of you have kidney failure, and that means your kidneys don't work anymore, and there's treatments for kidney failure. That's a very different conversation. So what I might suggest is that if we tip the balance from better nomenclature to better care, I think it helps both the researchers and the patients. It gives words accessible to help communication with policymakers and public. So we have March is Kidney Month in Canada, and on the side of the buses, we actually have like, do you know about your kidney health or something like that? And it's a really neat thing, but it's words that are accessible to the public. But if we said nephrology or renal, I don't think it would work so well. And then I think that, or I believe that better care and better research does require clarity and consistency. And perhaps if we all hold ourselves as slightly more accountable to use the right words in the right situation to express ourselves, I think we might get somewhere different. So these are just some nice tags that I find that I do think that words do matter. So with that, happy to answer any questions.